Hello, everyone. Welcome to KYSCO Oncology Voices, bringing you the latest in our state's oncology care and advocacy efforts. I'm Matthew Kurian, Treasurer and Executive Committee Member for the Kentucky Society of Clinical Oncology, or KYSCO. Every month, we're sharing expert advice from everything from research to practice management, and hope you'll tune in with us. Today, we're recapping key breast cancer updates from ASCO 2025 and how these may impact treatment decisions across academic and community settings here in Kentucky. I'm joined by two fantastic guests, Dr. Brian Dong from the University of Louisville and Dr. Arays from the University of Kentucky. Each guest will summarize one major trial in under 5 minutes, highlighting the primary endpoint, key findings, and their main takeaways, followed by an open discussion on clinical impact and our Kentucky-specific challenges. Dr. Dong, Dr. Arays, thank you for joining us. So
thanks for having us.
Yeah, thank you. We'll walk into a little bit of some statistics first as well, too, within Kentucky. The lifetime risk for women getting breast cancer is 1 in 8 in Kentucky as well, too. And in 2021, there were approximately 4,600 invasive breast cancer diagnoses with roughly 700 deaths that year as well, too. That's close to about 15%, so very high during 2021. In terms of incidence mortality rates overall, if you look at the age-adjusted incidence rates between 2017 and 2021, the state is roughly identical to the national average at about 129 per 100,000. The female breast cancer mortality is 27.9 per 100,000, which is actually one of the highest in the United States. Within Kentucky, we have more of a rural and Appalachian disparities that exist within our state as well, too. And incidence, is typically lower in those rural and Appalachian counties compared to urban regions, but the amount of late diagnoses is significantly higher in Appalachian Kentucky, roughly 34% versus non-Appalachian 28%. And screening, lower mammography rates amongst those over the age of 50 in Appalachian counties of 68% in Appalachian versus non-Appalachian of 76%. Kentucky does rank number 1 in the nation for overall cancer incidence and mortality as well, too. So this is why it's so important to have these discussions regarding what we can do for our state as well, too. So we'll start off with the Destiny Breast 09 trial, and we'll have Dr. Dong go through sort of a summary of that trial for us.
Yeah, absolutely. And that's a great overview of breast cancer statistics and kind of geographic distribution, demographics, and all that. And certainly I think Dr. Arays and myself being at kind of the more centralized urban areas of Kentucky, that's something we're very mindful of in terms of when you're trying to coordinate care with these local areas and trying to make sure that there's no delays in treatment, that there's transportation for these patients, that there's monitoring for toxicities from these chemotherapies. All of it's a big challenge and requires honestly a big team and a lot of resources. So certainly very appreciative of KYSCO highlighting these things and hopefully working towards continued solutions with state legislature and obviously the physicians. So I'll talk a little bit about Destiny Breast 09. So I think trastuzumab deruxtecan is a medication or treatment that we're all very familiar with over the last 2-3 years or so. And then I think some of our colleagues in the lung space and potentially the GI space are going to become even more familiar with it. But I'll focus on Destiny Breast 09, looking at TDXD in the front line for HER2-positive breast cancer in the advanced setting. So the eligibility criteria included obviously HER2 amplified breast cancer patients. Asymptomatic or inactive brain mets were allowed. People that had recurrent disease had to have a disease-free interval of greater than 6 months from the last chemotherapy or adjuvant therapy. And then they did allow patients to have 1 prior line of endocrine therapy alone in the metastatic setting. No other prior systemic treatments were allowed in the metastatic setting. And there were 3 treatment arms. So one of them was TDXD plus placebo. The second arm was TDXD plus pertuzumab. And then the control arm was essentially a taxane plus trastuzumab and pertuzumab. For the data that was presented at ASCO this year, the TDXD monotherapy arm was not mature for results. So they really looked at just the control arm versus TDXD plus pertuzumab for this analysis. In terms of distribution, there were a fair number of patients included. There were 1,700 screened and 1,157 randomized. which ended up being about 380 patients across all three arms. In terms of demographics, about 49% were enrolled in Asia, about another 20% or so were Western Europe and North America, and then the rest of the world made up the last 28% or so. About 50% were de novo metastatic at time of for enrollment, and then the other 50% were recurrent disease. And then surprisingly, there was a low incidence of brain mets at time of enrollment, only about 6% or so in both arms that I'll be discussing. In terms of prior therapies, what you would expect in terms of chemotherapy, about 41% in both arms had prior chemotherapy in the neoadjuvant or adjuvant setting, and then certainly a lot of them had trastuzumab, pertuzumab as well. And then to the significant finding, obviously, in terms of progression-free survival. So by blinded independent review, the median progression-free survival for T-DXd plus pertuzumab was 40.7 months, and in the control arm with taxane plus HP was 26.9. And this p-value was certainly very significant, and it's a very impressive delta between the two arms. When you look at the subgroup analyses, in terms of de novo or recurrent disease, there was still a strong favoring towards T-DXd plus pertuzumab. In terms of hormone receptor status, there was also no difference in terms of the subgroup there. So positive or negative both favored T-DXd plus pertuzumab. And then they also had a fair number of patients that were detected to have PIK3, and once again did not have an impact on benefit from T-DXd plus pertuzumab versus the control arm. So, everyone wants to know overall survival as well. Unfortunately, this is, just kind of the first analysis update, and it is only about 16% maturity reached. So this is something certainly we'll be keeping an eye on going forward at, every major conference. And then they did include some data for PFS2 as well in the control arm. Certainly there's a lot of crossover. The median PFS2 was about 36.5 months, and then in the T-DXd plus pertuzumab arm, it was not reached yet. And then, once again, we're all familiar with this medication, and in terms of the toxicities, if you're using it earlier, you want to make sure these patients are able to tolerate it. And I would say for the most part, it's kind of what we expected. There were about 20% that required treatment discontinuation due to any adverse event in the experimental arm with T-DXd plus pertuzumab, compared to 28% in the control arm with THP. And then a fair number of patients did require dose interruptions in the experimental arm. So about 68% had to have some type of dose interruption, reduction, something like that, compared to just 49% in the control arm. And in terms of toxicity, other specific toxicity, so nausea, diarrhea, neutropenia, certainly what you'd expect the most to see in T-DXd with pertuzumab, and certainly look to be a little bit higher than compared to the control arm. And then pneumonitis, I would say, is the most concerning side effect when you're dealing with some of these ADCs, specifically T-DXd. They did note about 12% of patients with T-DXd plus pertuzumab to have any grade pneumonitis, and there were 2 grade 5s noted. So that is certainly something of interest to be mindful of. When you compare to the other Destiny Breast trials, I would say in the last few recent updates, they have been able to avoid grade 5. So it's interesting that when you use it in the earlier line, that they did have a couple of those cases seen. So overall, T-DXd plus pertuzumab demonstrated a statistically significant and clinically meaningful progression-free survival benefit compared to the control arm of taxane plus HP. Early overall survival data is still early, but looking to favor the experimental arm. They kind of summarize overall with a 44% reduction in risk of disease progression or death with T-DXd plus pertuzumab versus THP. So I'll stop the summary there. Certainly a lot to break down.
Yeah, definitely.
I don't know if you wanted to kind of chime in a little bit or have me kind of keep talking about it, but
yeah. I think that great overview, Brian, regarding everything. I mean, I think that the Destiny Breast 09, I think is something that everyone is looking forward to in terms of, I think this ASCO was the first ASCO that we had an update, a major update in all different disease types: HER2 positive, triple negative, ER/PR positive. So it was a great ASCO for that reason. Now we have to sort of understand exactly, okay, which of these are really practice changing in your mind and in both of your guys' minds, and which are the ones that we need a little bit more information for. So I'll start out with that question first, exactly, for both of you. Is this something that, after ASCO is finished up, are you guys starting to use this in your own patients? Are you moving TDXD up to the front line for your HER2 positive folks? And if you are, sort of explain why you're doing that. And if you're not, tell me what makes you a little hesitant as well.
Yeah, I guess I'll go first. I think the conversation in the front line definitely changes. I when these conferences are going on, it's always interesting to check kind of the post session debriefs or social media with X and whatever else you may use to see kind of the pulse of the conference. And I would tell you, it's quite the mixed bag, right? I mean, I think the data that presented, to me seems very impressive, which is kind of what I associate every time I get a TDXD update of any kind. But at the same time, this is a medication we have a lot of experience with, right? And I think
Right.
most, especially breast-specific providers, are going to have a lot of experience of patients, having, I don't want to say failure to thrive, but certainly experiencing more symptoms once you hit the 6-month time, the 12-month time, the 18 months, 24. It's a medication that works very, very well, but patient tolerance, definitely there are significant side effects and impacts on quality of life. Things that I think you should definitely consider this upfront. I think burden of the disease is something that you should take into account. Maybe tolerability. Is this a patient that can be on toxic chemotherapy for potentially 2-3+ years, right? Based on the data from DB09. The other thing that you're weighing against, right, is that on the control arm, there's a maintenance phase, right? And during the maintenance phase, there's no chemotherapy. And those patients do significantly better in terms of quality of life, tolerance, and being a mom, being a functioning member of society, and kind of living their day-to-day life normally. And then on top of that, I think you have to consider the data from San Antonio with the Patina trial, right? Where for
Correct.
the
Yeah, definitely.
HR positive, HER2 positive patients, which was about 50% of the people on DB09, they may have an alternative option to boost the maintenance phase without chemo, right? With palbociclib, an oral CDK4/6. And that data was also very impressive. Now, I should say that it's not updated on the label yet. I think the indication is still pending, but I have talked to other oncologists that I think are starting to implement that where they can. So it's really hard to, identify at the very beginning who's going to have a better track with just going to TDXD up front plus pertuzumab versus, a THP and then a, amplified maintenance phase. So,
Right. Yeah.
I think it's an interesting conversation. I'm very curious what Dr. Arays' opinion is also on this, but I will say I'm certainly leaning towards favoring the recent update with TDXD pertuzumab, but it's still an ongoing debate and will be ongoing probably for the next 2-3 years.
Perfect. Yeah, Dr. Harris, what are your thoughts on the Destiny Breast 09?
Yeah, great summary of the trial too. Kind of the relevant points. Certainly, the data is very promising and interesting. And I think to Dr. Dong's point in terms of tolerability, I've started considering this in the patients where I have some concerns that they might be able to tolerate like the taxane part of the THP up front. I actually have someone I'm going to be seeing in the next few weeks who's a transplant patient, a solid organ transplant patient. And historically, I've not had a lot of luck with those patients tolerating conventional chemotherapy very well. We're usually not able to get more than like a cycle or two in, and it sort of defeats the purpose. So something like this where it's not quite hopefully as toxic up front is certainly something to consider, although the long-term effects are certainly concerning as well. I've had people on Enhertu for, I think the max has been maybe 4 or 5 years. But once we get to that point, oftentimes you're talking about taking some breaks here and there just because it is tough to be on this for long periods of time. And something like this, that's kind of what the patient would be stuck with. And then, the other thing that I always think about, unlike in triple negative breast cancer, where our second, third, fourth line options aren't fantastic, HER2 positive disease has some great salvage therapies down the line. So even though we're maybe moving this to the frontline setting, we still have some good options at progression and other things that we can offer the patient. So I'm definitely starting to consider this, especially for those where the chemo part of things worries me a little bit. Certainly, again, the data is looking very, very promising, and I'll be curious to see what happens in the next few years.
Yes, definitely. And I think that you bring up a lot of points in terms of, how much is too much? When do we, pull back exactly, give breaks, dose reduce, things like that, because as Dr. Dong sort of outlined, there are, some more significant toxicities, specifically the pneumonitis. There was a presentation about ILD rechallenge, that was presented as well too, that, makes it a potential option for safely retrialing, TXD for those that maybe develop grade 1, grade 2 pneumonitis as well too. So that I think it was good data to see that as well too. But I think you guys are both correct in saying that we don't really know exactly how things are going to work, and it's going to be a little bit individualized in terms of the patient. I think of the folks that maybe have brain metastases up front as well too is maybe where I'm potentially employing this strategy, fairly confidently as well too up front, given the data of intracranial activity in here as well too. And then question really, regarding just the sort of the design of everything as well too. How truly necessary is this pertuzumab in the grand scheme of things? We obviously don't know the results of the monotherapy arm yet as well too. How much is that really playing a role into things? I don't know if we have an answer to that as well too. And so if you guys are using this regimen in the upfront setting as well too, what's your second line option then at this point in time, after someone progresses? Are you using more of that, THP, or are you using more of a HER2 climb regimen as well too? What are your guys' thoughts in terms of how this shifts your practice in the subsequent lines of settings?
Yeah, so real quick to answer the monotherapy question, I would say we'll tell you probably in a year from now when that one probably gets released.
Right.
So it'll be very interesting to, fortunately it's all the same trial, so you can look at TXD versus TXD plus pertuzumab, right? Is there a significant difference there? What are the toxicities? So, we'll get that information at some point. It's just going to take a while. When you look at second line, and real quick too, in terms of brain metastases, I'll stress again that that was not a majority of patients on this trial, right? I mean, really, it was about 5%. And once again, they were, inactive or asymptomatic. So certainly, if someone's presenting, either de novo or they're recurrent with, brain disease, I think that's, certainly a high risk patient for, having a worse outcome. So I think, using your best hand, being more aggressive up front makes total sense. The other way to flip that is, and Dr. Arays brought it up as well. A lot of times when these patients do progress, whether it's already in the metastatic setting, second line, third line, whatever, they will progress with intracranial disease, right? So maybe there's some delaying of that process if you use TDXD in any combination up front, and that's something we'll have to keep an eye on as the data matures. So, with about 380 in each arm, hopefully we do get some of that input in the next couple of years.
Definitely.
Looking at second line, I think it's going to be a very interesting discussion, right? This is almost a data-free zone to look at THP second with a maintenance phase in the second, right? How long is that going to last for? I don't know, right? But certainly you can imagine an instance where someone's finished, let's just say at least a couple of years of TDXD monotherapy or pertuzumab, where they're fairly beat up and just, I don't want to say exhausted, but, certainly significantly fatigued, where, I may say, hey, this person would definitely benefit from, maximizing a maintenance phase of HP as best I can. And then, if they're triple positive, hormone receptor positive and HER2, can I even still use palbociclib in that setting? I don't know the answer, right? And then, if there's brain progression, I think it's an easy transition to a HER2 climb regimen. Xeloda at the same time too is I know in certain settings very well tolerated, but I think when you combine it with two other agents, with the tucatinib and the trastuzumab, then the mucositis kind of wears on you a little bit more, right? The GI symptoms a little bit more. So I still think there are great options afterwards, and it's just going to depend on what's the setting at time of progression.
Definitely. So, okay, guys, for the sake of time, we'll move on to the SERENA-6. So, Dr. Arays, could you give us a summary of the SERENA-6 trial?
Absolutely. All right. So this is one of the plenary abstracts at ASCO. It's a phase 3 switching trial of camizestrant, which is a selective estrogen receptor degrader, one of the novel SERDs, in ESR1 mutant breast cancer during first-line treatment. So I'm just going to go through a little bit of background. So ESR1 mutation is it's a frequent cause of acquired resistance to AI CDK4/6 inhibitor in first-line setting for advanced estrogen receptor, progesterone receptor positive, and HER2 negative breast cancer. resistance is often associated with alterations in genes involving ER signaling, growth factor receptor signaling, cell cycle regulation, and apoptosis. So ESR1 mutation is actually rare in endocrine therapy naive patients. It tends to occur, the data varies a little bit, at least 30% of patients who have had prior AI therapy, but some studies stay as high as 50%. There are prior trials kind of looking at this mutation a little bit. PADA1 is the precursor probably to SERENA in terms of some of the questions it's asking. That was showing a median of approximately 14.2 months from starting first line CDK4/6 with AI to detection of the ESR1 mutation. And it appears the mutation was detectable approximately 3 to 6 months prior to progression. The PADA1 trial switched people to fulvestrant. ESR1 detection was documented, and that theoretically led to a longer PFS. So the conclusion they came to was that ESR1 detection is associated with shorter PFS on subsequent AI therapy compared to those without the mutation. So back to the SERENA-6, this was a double-blind phase 3 study looking at efficacy and safety of switching from AI to camizestrant while maintaining the same CDK4/6 inhibitor upon detection of ESR1 mutation in circulating tumor DNA before clinical disease progression on first-line therapy. So kind of a lot of moving parts in this one. So inclusion, pretty standard, obviously confirmed hormone receptor positive, HER2 negative advanced breast cancer. Patients received at least 6 months of first-line AI, the CDK4/6 inhibitor, with no evidence of progression. They didn't specifically say they did not allow, or they did or did not allow brain mets. They didn't allow symptomatic brain mets. It wasn't part of the inclusion criteria, but part of the exclusion. They were also allowed to have at least one prior line of chemotherapy, though no prior, I believe, anti-estrogen therapies. So every 2 to 3 cycles, the patients had tumor imaging and ctDNA for ESR1 status. If ESR1 mutation was detected by ctDNA, the patient was then switched to camizestrant, 75 milligrams daily, either if no progression or actually they noticed progression on imaging. So they kept the same CDK4/6 inhibitor and placebo for AI versus continuing on the same AI and CDK4/6 inhibitor with placebo for camizestrant. So that's kind of how they controlled it. The primary endpoint was progression-free survival. The secondary endpoints, including were time to second progression event, PFS2, and overall survival. So at this point, at this interim analysis, so about, I think more than 3,000 patients were actually enrolled, but they waited until they had about 315 patients with ESR1 mutation detected to randomize those to either receive camizestrant or continue on their AI. So with that, the data that they presented showed that PFS was prolonged in those who were switched early to camizestrant. So it was 16 months in those who switched versus 9.2 months who continued on their AI. The PFS benefit appeared consistent across subgroups at 12 and 24 months. The PFS2 data did not meet their I think significance threshold. The hazard ratio was 0.52. It's only at 27% maturity though, so they're not quite there yet. And the OS was immature. I think it was only at 12% of where they wanted to be. It appeared that camizestrant with the CDK4/6 inhibitor was well tolerated. Safety was consistent with what was known of the drug beforehand. And it appears in combination, there wasn't any new safety signals that they found. Discontinuation due to adverse events was 1.3% in the camizestrant arm and 1.9% in the AI arm. And then I think one of the more interesting things that they found was that the quality of life was preserved longer in patients who switched early as opposed to those who continued on their prior AI. So that's kind of a brief overview of everything. It was an interesting trial, a lot of points brought up, a lot of discussions during the actual presentation. Some of the things, obviously, there's still data that's immature. So the PFS2 and the OS are going to be the very interesting, important parts of this that we probably need, because the PFS on its own, it's we certainly still have a lot of questions on that. One of the things that was brought up was that, are we potentially burning through a reasonable line of therapy by switching them early? Basically, what's the benefit of doing that at ESR1 detection, as opposed to when we actually see true progression? Are we actually gaining any benefit from doing this early, or is it possible we would recoup that time that we're getting on the early switch from just switching at the point where we see progression and other issues? There's some criticism of the prior PADA-1 trial too. I think it was an open label design, obviously, and there were some questions about the centralized imaging interpretations, some questions of bias. So even that earlier study, we had some concerns with that as well. So it's kind of a very promising, interesting situation, but in terms of how ready is this for prime time and for having this conversation with hormone positive patients in the first line setting, I'll be very curious to see what Dr. Dong says as well. I think we don't have, at least personally, enough information to necessarily go full press with this right now. I certainly would be talking about it with patients and considering it. But I mentioned the quality of life benefit for continuing or for switching. I could certainly see that being appealing to patients and that being a reason for someone to want to switch to something like this early. But I worry that without having more mature data, we might be potentially kind of, like I said, burning through a line of therapy, which we maybe didn't need to do quite so soon before we really know that's the best thing to do.
Sure. Yeah, no, I think you bring up a very good point in this. And then, and question for both of you guys, what is it going to take, to convince you of this approach exactly? You're sitting with a patient, later today in clinic as well, too. They see the press release online as well, too. They are potentially progressing as well, too, or maybe having signs of it, but maybe haven't gotten imaging yet as well, too. You potentially get an ESR1, that's found on liquid biopsy as well too. What's your conversation with those patients that, are looking at this data and saying, wow, this progression-free survival looks pretty good. And then in addition to that, the quality of life was very impressive. I mean, 23 months versus 6 months to time to deterioration as well too. So not only, are you potentially delaying progression, but also improving quality of life. What's your conversation with those patients exactly? What endpoint are you looking for? Are you looking for PFS2, PFS3, overall survival? What's your sort of conversation with your patients, guys, regarding this?
I just had a chill hit my body when you said PFS3. That really scared me a little bit there.
Yeah.
I'll jump in. I mean, first of all, a great overview on a very stimulating trial on the plenary session, and so great job, Dr. Arays there. And I think HR positive advanced disease is quickly becoming probably one of the scariest things for a new trainee fellow to kind of tackle on, right? Probably that, and maybe all the new CAR T trials coming out in malignant hematology, right? So to me, this is almost just as you start to feel like you're getting a sense of what your treatment algorithm is with the mature overall survival from the CDK4/6 is, then this wrench gets thrown in of SERDs, right? And what is it going to take? It's going to take a lot of time, a lot of subgroup analyses. I do think PFS2 in this setting is critically important, and on top of that, it's also the number of people in the experimental group that, or I guess either group the control group that go on to SERDs second, whether it's SERD per the EMBER-3 regimen, whether it's SERD with enilocestrant, or now with the recent, vepdegestrant, which I think we may try and touch base on. You have multiple SERD options in the second line, and some of them are, the EMBER-3 regimen is agnostic of, PIK3 mutation or anything like that. So what's going to have to happen first is all those are going to have to go through the approval process and then be available, and then we look at the analysis of those. So truthfully, there's going to have to be a lot of real world analysis, probably 2, 3, 4 years down the road that'll hopefully hash some of these out. On top of that, I have to know that I can send NGS, even if it's liquid, every 6 months and have it covered, right? I don't want to get the first one covered As only 50% of
Yes.
patients were presents, right? The other 50 were 12 and 18 and whatever months. So I don't want my patients to be hit with I don't know, $500,000, $2,000 bill every time.
Yes.
And then on top of that, you got to have CAMI available, right? So it's still not quite
Mm-hmm.
available, and I'm sure they
Hmm.
got the FDA fast track, so probably in the next potentially this year or early next year it'll be available, and then that conversation can happen a little bit more seriously. I'm in the same way as Dr. Ayers. I think there's still some hesitation. You can have some optimism. I think that's reasonable. The quality of life, time to deterioration, I'd have to look at the scale for that. That's not something I'm super familiar with. I mean, there's plenty of quality of life measures that we've seen a lot, but time to deterioration is a new one for me that, I think sure is a nice adjunct onto survival data, but survival data is still the most important.
Hmm.
Overall survival, my opinion on overall survival in HR positive is that it's almost impossible to standardize, right? When you're looking
Sure.
at global trials, the way things are happening in Asia compared to Europe, compared to the United States, it is just incredibly difficult to standardize. So
Hmm.
I think that will really put a lot of emphasis on PFS2. And truthfully, my personal opinion, just in general with this space, is that real world data actually carries a little bit more weight than maybe some of the other settings where there may not be as many therapeutic options. So you have to
Sure.
rely on real world data to kind of hash out some of the things that as they become available. So I forgot the original question, but that's kind of my approach to this space, and it's
No,
gonna
definitely.
my answers and probably everyone's answer is going to change every 6 months with more updates.
Mm-hmm.
Yes, I would agree. Yeah, I think it's definitely something it's a moving target right now as well too. And you hit on a point I wanted to talk about more specifically to Kentucky as well too. We have two bills passed within the last 2 years or so. House Bill 180, which guarantees insurance coverage for biomarker testing that guide therapy decisions. That was in 2023, and then House Bill 52, which is effective as of January 1st, 2025, requires insurance to cover guideline recommended screening and testing without cost sharing as well too. So in terms of the testing, say this does, pan out as well. This is an approach we use 3, 4 years down the line as well too. How easily available or how easy is it for our patients to get these liquid biopsies as well too? Is it something that you think will be a challenge within Kentucky? Are there things that we as an organization should be thinking about to sort of best support our patients at the state level? What are your guys' thoughts on that?
Mm-hmm. And I think in terms of where Dr. Dong and I are, I believe we have pretty reasonable access to liquid biopsy tissue testing. I would assume that's the case for you and Val as well. We typically don't have too much problems getting these done. The interesting thing in this study too is that you have to kind of do it every 2 to 3 months basically, and the coverage
Correct.
does get, then you do want to make sure that that's covered. And
Hmm.
that's not something we're doing tremendously right now, not consistently, because there's still a lot of questions about ctDNA as well. So in the community, I've noticed there's certainly a fair bit of testing up front, but I'm also not sure in those spaces how feasible or practical it is to test this frequency if all the same platforms are available. I've seen feel a fair bit of Keras and Garden in the community, but I'm not sure that I've seen much of Signatera or some of the other ones. So I think it does depend. I think it's pretty inconsistent throughout the state in terms of what's there, what's being done, how frequently. Not a lot of standardization from what I've noticed.
Yes, and I'll speak in my setting as well too. Many of my patients, I'm sure similar to your guys, drive maybe 1, 2 hours maybe as well too, sometimes to come see us as well too. And I think that, with the advent of many companies now offering like mobile phlebotomy and other things like that, I think it becomes a little bit easier as well too. But at the same time, I think the cost part of things, I think, is something that we'll definitely have to keep in mind as well too, is sort of Dr. Dong had outlined as well too, in terms of this test and many of these liquid biopsy tests, many in the pipeline as well too, and then many that are being used. The Garden platform, I think, was used in this study as well too. But really being able to make sure that those costs are things that our patients, don't have to suffer through as well too, and that they are covered as well too. And I think that is something that'll be also a little bit of a moving target as we get more information for this type of approach as well too.
Yeah, and one
So
more kind of quick thing on that. I
yeah,
think, sorry to interrupt you, but I think part of the onus is going to be on these companies, right?
right,
They have an army of sales reps, of MSLs, of marketing people, to reach these community places. And I've had very good conversations with Several of the companies we know of, Garden, Tempest, in terms of, hey, what's your access to some of these rural parts? Are you guys able to get into the offices? Are you able to get the kits to these providers? And then obviously the cost and, turnaround times and those kinds of things. So I think they are very aware of these changes in HR positive disease. I think they're understanding that there's going to be an onslaught of, or I shouldn't say onslaught, but there's going to be a moving target here in terms of how frequent we're going to want testing. And then I think what may be the bigger, I don't want to say challenge, but just the kind of the bigger decision for the providers, which company do you use, right? Which one's the best one? And, I think, depending on, maybe some of our, people that focus more on thoracic disease, it is, I would say significantly more important to identify those driver mutations, whereas in breast cancer, there's really only a core few that we really look at. So, in terms of which one you pick, if you can get pharmacokinetic information, I mean, there's going to be a whole bunch of things that are going to thrown at us. And I think it's just going to be on the companies to make sure that the availability, the costs, the turnaround, all that process, I think, fortunately, that'll be one thing not on the providers. That's going to have to be on them to hammer out.
Right, without a doubt. And then last question, just to wrap up this section, guys. So, we talked about this approach of, with the SERENA-6 of switching, to an oral SERD as well too, and potentially continuing the CDK4/6 as well too. Compare this to sort of the data that we saw, in San Antonio last year, the EMBER-3, imlunestrant plus abemaciclib of, switching to that treatment as well too, or, the ones we're waiting for, like the SERENA-4 and the Parsifal, where we're using an oral SERD up front as well too. What approach do you think, if you can predict the future exactly and think about, which approach you think is going to be the one that pans out the most, which approach are you the most excited about in terms of, what you think is going to have the most impact long term for a patient?
Yeah, that's a good question. I think honestly, and it's so hard to predict because again, we're still waiting on so many of these things. But I was more intrigued by the EMBER-3 data and what they were seeing there. I'm curious to see what the kind of final conclusions on that one would be. These where we switch early, where we kind of base things on the ESR1 mutation popping out. Almost all the trials that have been done in this space, even though they've shown some PFS improvement, I feel like long term, those the differences were not huge. And I like I said, I still have a lot of questions about what we're gaining by early switching, as opposed to kind of responding a little bit down the line, although again, we will probably figure that out as we go. But I think I'm kind of leaning more toward Ember than Serena at the moment, but who knows? We'll see in the next few years how things go.
Perfect. Dr. Don?
Yeah, I'll just say that I think the amount of time it's going to take for us to say we're bought in, we're going to make a change, is just going to take even longer, right? I think with the CDK4/6s, we look really at overall survival, but I think it's going to be unreasonable to wait on a new therapy for 5-6 years when there's already some upfront within a year or two that may be encouraging. So, PFS2, I think, will become a little more important. And, it's kind of funny that I feel like Sonia trial was the first time I really kind of saw a lot of highlight on PFS2. And now it's going to be a major thing with SERDs in the second line. So I think what's going to change, if I'm looking 5 years down the road, is that I think there's going to be even more target combinations that are come out. I mean, the one that comes to mind that is coming is a kind of epigenetic mechanism with the histone acetyltransferase or the HDACs, or I shouldn't say HDAC, but just targets in that pathway. There's a Pfizer clinical trial that we have looking at that agent that had some promising phase 1, phase 2 data presented in San Antonio last year. So I think it's going to come down to maximizing your front line best you can, whether that's SERD up front or a switch strategy, and then hopefully having a increased number of options in the second line, not just pick 3, not just SERD, but potentially, hopefully, a host of other things. And then the next question is going to be, how early is too early for chemo, whether it's TDXD, whether it's sacituzumab, whether it's, I don't know, HER3, right? HER7, who knows, right? But I do think the future second line is going to become even more hotly debated, which is going to make front line even harder to justify, making a big change because you don't want to see longer follow-up. So it's all good things. The things I tell to trainees or I tell to these, companies is, give us as much information as you can and let us make those decisions with the patient. So I think that's
Mhm.
the more we have, the better we can make those decisions.
Correct. Definitely, definitely. Perfect. Well, we'll move on to our last trial, the ASCENT-04. So, Dr. Dong, can you give us an overview of that study?
Yeah, so this one will be quicker than my TB09 overview. I think this one's a little bit more straightforward. So once again, another antibody-drug conjugate we're all familiar with in sacituzumab govitecan or Trodelvy. So ASCENT-04 was to look at sacituzumab in the front line in combination with immunotherapy in patients with or that that are PD-L1 positive with a CPS defined by greater than or equal to 10%. They did allow people with recurrent disease to enroll as long as there's greater than 6 months disease-free interval from their last treatment. And then I think very importantly, they did allow prior PD-1 use as well. So they randomized them 1-to-1 with sacituzumab plus Pembro versus chemo, investigator choice plus Pembro. And the chemo options are what you would expect in paclitaxel, nab-paclitaxel, gem-carbo, along with pembrolizumab, and basically followed them until progression. So the main endpoint was progression-free survival, and obviously looking at overall survival and quality of life in the secondary measures. They did include a fair number of patients, so I think the trial in total included 443, so it's about 221, 222 in each arm. And I will say that I do give them kudos for detailing out their racial distribution. So, it's predominantly Caucasian. It looks like it was 63% in the experimental arm and 53% in the control arm. But they did also include that there were 6% African Americans in the experimental arm and then 5% in the control arm. And a lot of times, we don't even get that level of detail. About 38% were in I also say the Western Hemisphere with the United States and Western Europe, and then the rest of the world is about 62%. So once again, a global population, which I do think is important to have with triple negative breast cancer. About a third of patients were de novo metastatic, and then the rest were recurrent within, basically over a 6-month period from last interval of treatment. When they looked at progression-free survival, so sacituzumab plus Pembro, the median PFS was 11.2 months versus the control arm of chemo plus Pembro of 7.8. This difference was statistically significant. And, the 12-month progression-free survival rate also looks pretty encouraging at 48% for sacituzumab versus 33% for chemo. They also looked at duration of response in the different arms, which I think is an important thing too, right? If you find the right treatment that someone can respond to, I think, maybe not to the same level as the other ADCs, but, I think a lot of us have had people get sacituzumab and do fairly well, even with the known toxicities. So the median duration response on this trial for sacituzumab and Pembro was 16.5 months versus 9.2 months in the control arm. So I do think that's an important point of, trying to identify those patients that are going to respond better earlier, especially in a setting that is more aggressive. When you look at the subgroup analysis, certainly in terms of, patient age, geographic distribution, recurrent disease versus de novo, all these arms tended to favor sacituzumab plus Pembro, which is reassuring. And then in terms of toxicities and safety, interestingly, I would say, it's probably not a surprise because the control arm is still going to be quite toxic. In terms of adverse events leading to treatment discontinuation, it was 12% for the sacituzumab arm and then 31% for the chemotherapy arm. Although I will say both cohorts had a high rate of interruption or delay, where it was 77% in the sacituzumab group and 74% in the control group of chemo. The toxicities are kind of what you expect. Neutropenia was certainly the most common seen in the sacituzumab group. And, we don't have to go into all details of this, but, certainly there's been a lot of data looking at, what's the appropriate use of growth factor, when is the nadir most likely to happen, how do we manage these things? And I think, once again, providers are getting more and more comfortable with that. And then certainly, fatigue, nausea, diarrhea, things that you'd expect. So overall, this ASCENT-04 is a randomized phase 3 study looking at the efficacy of sacituzumab with pembrolizumab in appropriate patients in the front line for triple negative breast cancer, and a statistically meaningful improvement in progression-free survival compared to standard care with chemotherapy and Pembro. So, overall survival wasn't reached yet. That'll come hopefully in the next year or two. And, the safety profile matched what we are familiar with sacituzumab. So, I do think it's an exciting update for triple negative breast cancer patients. A lot of these patients don't really make it to, second or third line, just, after disease progression can be quite significant and serious. So maximizing outcomes up front is critically important.
Definitely. Great overview, Dr. Dong. And I think you touched on a little bit of, I think with a lot of these newer ADCs as well too, of, comfortability in terms of managing side effect profile, I think is something that has become more important, especially in the community setting as well too. And I think sacituzumab specifically, I think has been a more misunderstood drug. I think in terms of providers maybe trying it and maybe having some bad experience in terms of diarrhea or neutropenia or things like that as well too. And I think as a result of a lot of the newer data that's come out, and a recent label change that they made that required primary prophylaxis as well too. It wasn't on the original label, and then studies like the PRIME study, sort of outlining ways to sort of manage toxicity of diarrhea, with prophylactic loperamide and using growth factor in a different way as well too. I think I've really changed in terms of how we manage it, because I do think it's a good drug, and I think that if you look at the original trial, that was a very heavily pre-treated population of individuals, so, and now we're moving up the front line as well too. So I think I was, happy to see this result as well too. What are your guys' thoughts in terms of, using this regimen up front? Are you using it? Have you used it? Will you be using it up front for those that are PD-L1 greater than 10% or greater?
Certainly, it's something I like with all of these trials, am considering, and we'll probably be discussing with patients. Triple negative is such a tough one since, unfortunately, they progress quite readily. And the thing that I worry about with ASCENT-3 and ASCENT-4, Trodelvy has been a very useful second line agent in my practice, and I wonder what I would do in subsequent lines, because when they respond well for, let's say they do those 11 months, and after that, what do we fall back on? Do we go back to the chemo? Do we, basically that's all we have if they have no mutations or targets. And while it looks like a benefit in the PFS, it's not a huge one. So I still like with all of these, more time and a little bit more information would be good. I would certainly discuss this with patients, but I am curious to see kind of what the final results on these will be as well. But it's good to see the drug being used a little bit more upfront, and being kind of more comfortable with it now that it's been around for a little while.
Definitely. And we, this trial obviously focuses on those that are PD-L1 positive. We have the ASCENT-03 trial, that's looking at the PD-L1 negative population. What are your guys' thoughts in terms of, using SASI in upfront setting for PD-L1 negative as well too, now that we have some data regarding PD-L1 positive as well too? What's your thought in terms of using, not using?
Yeah, I think ASCENT-03 has been already declared a positive trial, but the data hasn't been presented yet. My guess is they'll probably wait till ESMO this year. I think, kind of like I mentioned with ASCENT-04, I think you want to try and identify the people that can respond better earlier, because then I think there's a lot of legs to get from these ADCs and from the non-chemo options. And as we get more comfortable navigating the neutropenia and the the GI symptoms, I personally, I think I've seen better tolerability than my initial experiences, kind of like you mentioned, in the heavier treated population. And sacituzumab, I think, has obviously there's a lot of comparisons to other ADCs in the space, and when you look at the HR positive data, you have to not let that cloud your view of the data in the triple negative setting. And I think the prophylaxis, as you mentioned with the PRIME study, was enormous for us, because when I talk to providers across the country, just through various outlets, they seem in their practice to have not as nearly as many issues with neutropenia. And I feel like for myself, whether they're 35 or they're 75, I just have a lot of issues with neutropenia if I'm not being aggressive with growth factor, even after the first cycle, or sorry, first day. Whereas a lot of other people were like, well, we may or may not do something day 9 or something, and then just call it, and everyone's fine. And I had a lot of issues with it probably the first couple of years it was out. And I've subscribed to the PRIME method. I think it's been very effective, and it's very easy to or we've had a lot of success getting it approved with insurance, whereas in the past, getting long polyanthic growth factor has always been a bit of a headache, especially before, it's added to the label. So, I think that makes troubleshooting some of the other ancillary stuff with giving sacituzumab a little bit easier. And then I think having more experience with it has helped a lot too. So I would certainly consider using it up front once this data gets presented. And, once again, triple negative, very different setting than HR positive. I think we're more willing to accept, novel changes earlier.
Right, definitely. So, Dr. Ayers?
Yeah, I think I would agree with those things as well. That it's a good point that we want to optimize our therapies up front for the triple negative patients and make sure that something that we choose is controlling the disease for as long as possible. It's always so discouraging to see the progression at 6 months, a year. So anything we could do to keep that sustained is definitely a plus. The toxicity, as we were discussing, is becoming much more manageable and easier to handle for the most part. And we becoming more familiar with kind of dose reductions and different schedules to make sure patients can continue getting the drug. As I said, it's definitely something that I would be considering and talking to people. And always thinking ahead as well about what our options will be down the line. But it's all of the things that we saw in this ASCO are definitely promising and interesting. And I think what we keep coming back to is we definitely want to see more mature data, but at the same time, we're going to have to be making some of these decisions in the next couple of years before all of it is available to us, and maybe kind of going to some of these things like the SASI upfront or SASI plus Pembro to kind of give our patients better outcomes.
Thanks for tuning in to KYSCO Oncology Voices, a resource of KYSCO. If you have thoughts on the conversation, we'd love to hear them. You can write down your comments in at blawrence@accc-cancer.org. Click on the show notes to dive deeper into the topics we've covered today. We hope you'll follow along with us. Double check if you're following the show on your podcast player to get notified when our next episode is published. We'll see you then.